Hello everyone, welcome to Easy Medicine. Now we have this patient by name Rajesh Kumar, a 58-year-old banker who rushed to the emergency department tonight with a sudden and unsettling sensation in his chest. He describes it as his heart is racing uncontrollably and fluttering after watching TV while he was having dinner. Okay? At first, he thought it might be just some kind of stress or something he ate, but when the feeling didn't go away, he decided to check his pulse. That's when he noticed something strange. His heartbeat was irregular and almost chaotic. Now he came to the casualty, and you are there to examine him. On examination, you found that his heart rate is 140 beats per minute, but here's the catch. It's irregularly irregular, and his blood pressure is slightly elevated at 140 by 90 millimeters of mercury. He's also feeling a little short of breath, and he's also a little dizzy. There's no chest pain, no fever, and no recent illness. His medical history includes hypertension. Okay? And the first investigation that we did was an ECG, and here it is. What do you see here in this ECG? You can see that the R to R interval is quite chaotic or irregular, right? The R to R interval is chaotic, and you can also observe there are no P waves in the ECG. Okay? This is nothing but atrial fibrillation. Okay? Atrial fibrillation. What does the word tell you? The atrium is not able to contract properly, it is only fibrillating. Fibrillating means it won't be able to generate an efficient or effective atrial contraction. Instead, it is just fibrillating. Okay, let's delve deeper into this topic of atrial fibrillation based upon this outline. So, we are going to look at firstly the definitions, etiology, pathogenesis, clinical features, diagnosis, and management. In the management, we have rhythm control, electrical as well as pharmacological methods of rhythm control, and then rate control. After that, we have anticoagulation, and finally, different protocols accommodating all these different treatment modalities for the patient. Now, let's start with the definitions. The first one is a new onset atrial fibrillation. You call it as new onset when the patient is newly diagnosed, regardless of its duration and the severity of symptoms. Okay, so irrespective of this duration, when the patient comes to you for the first time and the atrial fibrillation is diagnosed for the first time, it is called as new onset atrial fibrillation. Now, paroxysmal atrial fibrillation is one where the episodes occur and they stop spontaneously within 7 days, but usually they stop within 48 hours. Then comes the persistent atrial fibrillation, where the episodes last for more than 7 days but usually resolve in less than 1 year. Then comes the long standing persistent atrial fibrillation, where the episodes last more than 1 year and they have not resolved yet. And lastly, we call it permanent atrial fibrillation, where the atrial fibrillation cannot be controlled anymore. Because here, the doctor as well as the patient have agreed that will not be able to restore the patient to normal sinus rhythm even with different kinds of attempts with drugs, or be it a pharmacological or electrical rhythm control. That is called as the permanent atrial fibrillation. Now look at the etiology. The etiology has been classified into multiple groups depending upon the systems involved, starting with the cardiac. Okay, so the structural abnormalities can result in atrial fibrillation, which are left atrial enlargement, atrial septal defect, atrial myxoma, rheumatic heart disease, which may involve and result in different valvular abnormalities like mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation. All of them can result in atrial fibrillation. And any kind of cardiomyopathy, be it HOCM or DCMP or RCM, any kind of cardiomyopathy can also result in atrial fibrillation. And finally, the coronary artery disease can also result in atrial fibrillation. As you can see, most of them are related to the atria. Okay, even MSMR will also result in left atrial enlargement, which will again predispose the patient to develop atrial fibrillation. And then some certain conduction abnormalities like tachycardia bradycardia syndrome, otherwise called as the six sinus syndrome, WBW syndrome, where there is an aberrant pathway of conduction. Instead of the AV nodal conduction, there is an aberrant pathway through which the impulses may pass through. And then kinds of cardiac stress. It could be stress on the left heart, or it could be a stress on the right heart. Right heart stress because of pulmonary embolism. Left heart stress could be because of hypertension. And hypertension is the most common cause of atrial fibrillation. The endocrine causes. What endocrine causes can result here? The patient can have hyperthyroidism. You are already aware of hyperthyroidism, where the thyroxine hormone itself can raise the heart forward. Initially, the patient may have sinus tachycardia, but eventually the patient may land up in atrial fibrillation. Pheochromocytoma, again a condition where there is excessive production of catecholamines. Under its influence, again the heart can race forward and may result in atrial fibrillation. Lung diseases like obstructive sleep apnea and chronic obstructive pulmonary disease can also result in atrial fibrillation. How? See, the obstructive sleep apnea or chronic obstructive pulmonary airway disease can result in hypoxemia, and the hypoxemia will result in pulmonary vasoconstriction. Okay, it is called as reflex hypoxic pulmonary vasoconstriction. When there is pulmonary vasoconstriction, the right heart should have to pump so hard, and the right ventricular pressure may result in stress on the right atrium, and that will further result in atrial fibrillation. Anything going back to the left or right atria can result in atrial fibrillation. That's what you need to understand. And then alcohol. Alcohol related causes like alcohol abuse, simply called as the holiday heart syndrome, where the patient would have consumed during a weekend, the patient would have had a binge alcohol drink, and the next day the patient would have developed this atrial fibrillation, that is called as holiday heart syndrome. And alcohol withdrawal can also result in this condition. Now let's look into the pathogenesis. So the origin of atrial fibrillation most commonly occurs at the openings of the pulmonary veins into the left atrium. As you can remember from the anatomy, the pulmonary veins open into the left atrium, and the opening of those pulmonary veins into the atria, otherwise called as ostia, are the primary foci for the initiation of this atrial fibrillation. And further scarring inside the left atrium, it could be because of any cause. It could be simple stress, it could be an infarction, whatever the cause may be. The scarring maintains the atrial fibrillation. The ectopic foci initiates the atrial fibrillation, and whereas the scarring in the atria maintains the atrial fibrillation. And initially, it may be paroxysmal, which may further progress along as it progresses towards persistent, long-standing, and permanent atrial fibrillation. Now, the atrial rate is determined. So let's look at how the atrial rate is going to affect the ventricular rate. See, this is a normal heart where the SA node is initiating the cardiac impulses, and through across the left atrium, it is going to reach the AV node. And further from the AV node, we have the bundle of his and the Purkinje fibers through which the electrical impulses are being forwarded to the ventricle, and the ventricle contracts. That is usual, right? So the atrium contracts under the control of SA node. Whereas in atrial fibrillation, these ectopic foci originating from the ostia of the pulmonary veins at the left atrium, they'll transmit into the right atrium as well. And they are quite chaotic. It is not under proper rhythmic control of the SA node, and these ectopic foci are going to give chaotic rhythm. And the AV node, it is called as the gatekeeper of the ventricles, right? So it is not going to allow each and every electrical impulse that is originating from the atrium. Okay, it is only going to allow certain impulses, because of which, even though the atrial rate may be around 200 or more, the ventricular rate is will be less. Okay, so the atrium fibrillates, and then the AV node filters, and the irregular ventricular rate is the result of up to 100 to 160, usually can be up to 200 as well. Now, because of this inefficient atrial contraction, what will happen? The blood is not going to be emptied into the left ventricle, and the blood is going to stay there in the left atrium. Because of this stasis, the blood may form into a clot, and the clot sometimes may dislodge and enter into the aorta, and it may pass into the systemic circulation, most commonly ascends into the carotid and then dislodges in the brain, resulting in a stroke. And the most common site of thrombus is the atrial appendage in the left atrium. Now let's see the clinical features. What did the patient come up with? Fluttering of the chest, or you can simply call it as palpitations. The patient usually come to you with palpitations, shortness of breath because of the failing heart, and then fatigue and weakness because the blood is not going to enter properly into the left ventricle. If there is no sufficient blood in the left ventricle, how is the cardiac output going to be, and how is the blood pressure going to be, and how would be the blood that is required for the muscles to function, right? So there is fatigue and weakness as well. Again, because of the reduced blood flow to the brain, the patient will have lightheadedness, dizziness, otherwise called as a presyncope or syncope as well. The focal neurological deficit can also occur if there is a thrombus that is dislodging from the left atrium and further passing through the aorta carotid into the brain. Now, what will you observe on examination? You can see an absent A wave on the JVP. Okay, A wave corresponds to the atrial contraction, and here the atrium is not contracting properly. It is only going to fibrillate. That is why it is not going to generate a proper A wave on JVP. Now, the diagnosis is primarily made by utilizing an ECG. Of course, clinical diagnosis may be made, but still there are a lot of irregular rhythms. For confirming, you need an ECG. The ECG detects persistent AF. Why? Because a paroxysmal AF patient may come to you with normal rhythm because the patient may have had an atrial fibrillation at home, but he may not be having atrial fibrillation at present when he comes to you. Okay, so the ECG detects only persistent AF. For the paroxysmal AF detection, you need a Holter monitoring or an event monitor or a loop monitor. Okay, and the ECG or Holter monitor detects the fibrillatory waves. Okay, instead of a P wave, we have fibrillatory waves, and you can see the P waves are absent, and there is an irregular ventricular response. That is why there is a varying RR interval. Okay, you can see the R waves are occurring at irregular intervals. Thirdly, we can look at the transthoracic echocardiography, which is required for identification of any cardiac structural abnormalities. And then we can do a transesophageal echocardiography, which is essential for identification of the left atrial appendage thrombus. For detection of the intracardiac thrombus, the transesophageal echocardiography is essential, whereas for structural abnormalities, even transthoracic echocardiography may be sufficient. So what will they assess? We'll assess the valvular heart disease, and then the brain natriuretic peptide may also be done, which is elevated in the atrial fibrillation because it is also generated from what? The BNP is produced from the ventricle, whereas ANB is produced from the atria. Chest X-ray will show you whether the patient's cardiac chambers are okay or not, or is there any enlargement, right? And we can also rule out the lung causes. We have COPD there as a cause, so we can also rule out lung causes. Even chronic interstitial lung disease can also result in pulmonary arterial hypertension, which can again predispose the patient to develop atrial fibrillation. So any other lung cause which results in chronic hypoxemia can put the pressure on the right heart and which may further increase the incidence of atrial fibrillation. Sleep study to identify obstructive sleep apnea, and certain routine blood investigations along with TSH, coagulation profile, and then the fasting lipid profile may also be done. And lastly, the mobile phone facial or finger photoplethysmography has a sensitivity and specificity of up to 95% for identifying atrial fibrillation. Now the management. As we have already discussed, in the management, we have rate control, rhythm control, and anticoagulation, right? So firstly, we'll see what are all the modalities that we have, and at the end, we'll see how are we going to incorporate all these modalities into our treatment protocol. Okay, so we have certain factors which will help in deciding whether to give rate control or rhythm control for the patient. So firstly, look at the factors favoring the rate control. The advanced age, older age, and with comorbidities means you need to give rate control. You need to start rate control for the patient because the patient's heart may not be, advanced age and comorbidities of life may imply that the patient could be having some kind of structural damage to the heart. Whenever the heart is structurally damaged, it is less likely to be reverted to normal rhythm. That is why we prefer rate control. And long-standing persistent atrial fibrillation as well. Again, this will result in structural damage. Severe left atrial enlargement, again a structural implication here, with or without the mitral valve disease. If we are not able to restore the patient to sinus rhythm using the rhythm control modalities, again you can still go back to the rate control. If the patient is not having very severe symptoms, then also you can opt for the rate control. What are the factors that favor the rhythm control? Now, if the patient is quite young, you want to restore the sinus rhythm immediately, right? Even if the patient is having new onset AF, it is a very highly likely chance that it may be reverted to normal rhythm. If the patient is having frequent episodes with severe symptoms, okay, if the patient is having heart failure or very severe symptoms also, you need to get the rhythm back to the sinus rhythm. And then if there is an atrial fibrillation which is precipitated by an acute illness, and then tachycardia related cardiomyopathy, and finally pregnancy as well, we need to think about the rhythm control first. If the patient himself prefers to undergo rhythm control, then also you can directly go ahead towards the rhythm control. So these are certain factors that help you in deciding between rate control and rhythm control. But in most of the patients, we may give both of them, right? But these will help you in preferring one of the two modalities that you have. Now let's talk about the cardioversion, otherwise called as the rhythm control. The cardioversion may be an elective cardioversion or an emergency cardioversion. Emergency cardioversion may be done when the patient is quite unstable. So what are the indications for it? If the patient is having hemodynamic instability, or if the patient is having ongoing ischemia or a myocardial infarction, or if the patient is having heart failure. Like we already discussed, heart failure is an indication to control rhythm. And if the patient is having WBW syndrome or any other pre-excitation, because see, when the left atrium is beating erratically, and as long as the AV node is there, the ventricular rate is being controlled to some extent, right? Because it is a guardian or a gatekeeper of the ventricles. It is not going to allow all the unnecessary impulses from the atrium into the ventricle. But if there is an aberrant conduction, like a bundle of Kent in the WBW syndrome, all the atrial impulses are transmitted through the aberrant conducting pathway into the ventricles, and the ventricles will also fibrillate. Okay, so the atrial fibrillation will result in ventricular fibrillation. The patient will die immediately. That is why any kind of pre-excitation or WBW syndrome is extremely life-threatening for the patient, and you just have to control the rhythm first. Now, elective cardioversion. Elective cardioversion may be done by using the elective cardioversion may be done using the electrical cardioversion first. For that, you will use QRS synchronized DC shock of 200 joules. Okay, this requires conscious sedation. Remember, we need to give conscious sedation or anesthesia for the patient before we administer shock. And we also have drug-based cardioversion, also called as the pharmacological cardioversion, where you will give certain drugs like amiodarone, flecainide, ibutilide, and propafenone. You can use all these drugs. In addition to this, you can also give the catheter ablation. What are you going to do? If you have identified the particular focus by the electrophysiological studies, you can also ablate it by using the radio frequency or cryo. Okay, so by using these two methods, you can isolate the areas of the left atrium which are acting as the foci for the development of atrial fibrillation. Okay, and you can also ablate them by using the surgical modalities, also called as the surgical ablation. Okay, and if the patient is having an infrequent episodes of atrial fibrillation without any structural heart disease, what you can advise the patient is called as the pill in the pocket approach. Okay, see, if the patient is having paroxysmal AF, or the patient will have the atrial fibrillation very occasionally, the patient may not be willing to take the drug all the time. Okay, so what can you advocate for the patient is a pill in the pocket approach. Pill in the pocket approach means the patient will have a pill with him in the pocket all the time, and you can whenever the patient feels the fluttering inside the heart, and if the patient feels that the rhythm is abnormal, then the patient may take this tablet. Okay, you can term is actually the intermittent antiarrhythmic drug therapy. You can simply put it as pill in the pocket approach. What can you use for this drug approach? Flecainide or propafenone. The drugs have been mentioned in the gray areas. You can learn it. Now come to the rate control. Okay, so rate control may be done by beta blockers or the non-dihydropyridine calcium channel blockers. Okay, so these are the first line, and these are essentially contraindicated in pre-excitation. Okay, so why are they contraindicated in pre-excitation? Let's suppose the patient is having a WBW syndrome. Okay, if the patient is having WBW syndrome, and if the impulses are being transmitted across the AV node, if you block the AV node, what are these beta blockers or non-dihydropyridine calcium channel blockers going to do? They are going to block certain impulses that are being passed through the AV node. So when these impulses are being blocked, the pre-excitation or the bundle of Kent or an accessory pathway comes into play, and the atrial fibrillation will become ventricular fibrillation, and that will result in death of the patient. That is why if the patient is having a pre-excitation or an accessory pathway, these rate controlling beta blockers or calcium channel blockers are contraindicated. Okay, a very important point to note. And the target heart rate is less than 80 in symptomatic individuals, and it is less than 110 in asymptomatic individuals with normal LV function. Okay. See, the other drugs that can be used are digoxin or amiodarone may also be used. Usually the digoxin previously, which was used for the management of heart failure, it is now primarily being used if the patient is having heart failure with the presence of atrial fibrillation. In addition to that, we have the ablate and pace strategy. Ablate and pace strategy means after having given these drugs, if you are not able to achieve adequate rate control, what you can do is you can ablate this conduction, the AV nodal conduction. Okay, so the AV junction is ablated using a catheter, and then a permanent AV blockade is created. Okay, but if the AV junction is completely ablated, there needs to be another pacemaker, right? So you need to implant a permanent pacemaker for this patient. Now we are at anticoagulation. Before we progress to the anticoagulation, the first step would be to assess the risk of stroke and the risk of bleeding before starting anticoagulation. How are you going to assess the risk of stroke? By using the CHA2DS2-VASc score. How do you assess the risk of bleeding? By using the Hasbled score. So firstly, let's assess the risk of stroke. So C for congestive heart failure, H for hypertension, A for age more than 75, and age more than 75 scores 2 points. Age, then comes D for diabetes, S for stroke or a transient ischemic attack or any history of thromboembolism, and then again A for age, which lies between 65 to 74. That gives you a score of 1. And then VA stands for vascular disease, and lastly SC stands for sex category, that is female. Here, if you look at the scores, the age more than 75 and the history of stroke will give a score of 2 points. If the score is more than or equal to 1 in men, then give anticoagulation. And if the score is more than or equal to 2, again consider anticoagulation. But also, along with the assessment of risk of stroke, you should also assess the risk of bleeding. Why? Because as soon as you start bleeding, if the patient dies of anticoagulation, there is no point, right? So assess the risk of bleeding as well by using the Hasbled score. Hasbled score, H for hypertension, A for abnormal liver function test, A for abnormal renal function test, S for stroke, B for history of bleeding, L for labile INR or high INR, E for elderly, age more than 65 years, drugs or alcohol. And if you count all the points, each of them has been given 1, and if the score is more than or equal to 3, then the patient is most likely is having a high risk of bleeding. What would you do? You should address at least the modifiable risk factors. For example, age may not be altered, but if the patient is having uncontrolled hypertension, you may be able to control it by using the drugs. Okay, so the modifiable risk factors may be controlled to bring back the Hasbled score to less than 3. So after assessing the Hasbled score and CHA2DS2-VASc score, have you decided to anticoagulate? If yes, then if the patient is a valvular AF means the patient could be having an mitral stenosis or a prosthetic mitral valve replaced. Okay, so a prosthetic mitral valve replacement or a mitral stenosis, you call it as valvular AF. Then in those, you will start warfarin with a target INR of 2 to 3 and you will monitor the INR monthly. If it is a non-valvular AF, that is without mitral stenosis, then you can give novel oral anticoagulant drugs, right? And if you have decided not to anticoagulate, you can at least start the patient on aspirin and clopidogrel. Okay, that is what you are going to do after you decide to anticoagulate. But after assessing the bleeding risk, now that you are not able to control the modifiable risk factors and you have considered and you have come to a conclusion that it is not able to, if you are not able to give anticoagulation for the patient, what can you do is you can still be possible to control the thrombus by surgically removing the appendage or by doing the atrial maze surgery, okay, or an atrial maze surgery. You can also deploy a percutaneous devices that occlude the left atrial appendage. Okay, the left atrial appendage is the primary focus for thrombus inside the left atrium, because of which you deploy certain devices which will occlude the left atrial appendage, thereby preventing the thrombus. Now we are at the end. Let's just discuss the protocols now. So the protocol of the management of acute atrial fibrillation with the rapid ventricular rate. Okay, so if the patient has an acute atrial fibrillation with the rapid ventricular rate, firstly see whether the patient is hemodynamically unstable or stable. If the patient is hemodynamically unstable, meaning if the BP is less than 90/60, or if the patient is having any sign of shock or ischemia or end organ hypoperfusion, or if the patient is having severe pulmonary edema, now the next best step is to do urgent DC cardioversion by giving a conscious sedation or anesthesia, like we discussed previously. And prior to the starting DC cardioversion, you need to give a parenteral anticoagulant, most probably heparin or low molecular heparin or unfractionated heparin. Okay. So after DC cardioversion, you are going to give 3 to 4 weeks of post cardioversion anticoagulation. Okay, the anticoagulation that is given post cardioversion is for a duration of 4 weeks. Okay, and now the 4 weeks is mandatory for each and every patient of atrial fibrillation who has been cardioverted. Now, after 4 weeks, if you want to decide on long-term anticoagulation, now comes the need for the usage of CHA2DS2-VASc score. So, depending upon the score of that is the CHA2DS2-VASc score, now you can decide on the long-term anticoagulation for the patient. That is, if the patient is hemodynamically unstable. Now, if the patient is hemodynamically stable, then firstly ask for the atrial fibrillation duration. If the duration of atrial fibrillation is less than 48 hours, or if it is more than 48 hours. Why is this 48-hour duration? If the atrial fibrillation duration is short, the likely formation of thrombus inside the left atrium is low. Okay, but if it is more than 48 hours or if the duration is unknown, then the likely chance of thrombosis inside the left atrium is high. Okay, that is why we consider atrial fibrillation duration first. If the duration is less than 48 hours, then wait and watch and see if the atrial fibrillation reverts back to normal sinus rhythm spontaneously. Otherwise, you can perform cardioversion there. Okay, after waiting for 48 hours. But if the patient is having the atrial fibrillation of duration more than 48 hours, or if the duration is unknown, then firstly, what you can do is transesophageal echocardiography for the assessment of the left atrial thrombus. But if yours is a center where the transesophageal echocardiography is not available, then start the patient on pre-cardioversion anticoagulation that needs to be given before cardioverting the patient, right? So it is called as pre-cardioversion anticoagulation for 3 weeks, and after that you can cardiovert the patient. Okay, that is what we do if the transesophageal echocardiography is not available at your center. But if the transesophageal echocardiography is available at your center, do it and assess for the presence of intracardiac thrombus. If the intracardiac thrombus is ruled out, then you can cardiovert the patient within 24 hours. In either way, eventually, After cardioversion, you are going to continue 4 weeks of post-cardioversion anticoagulation, similar to that of the previous protocol of hemodynamically unstable patient. And again, after this, assess for long-term anticoagulation based on the CHA2DS2-VASc score, and also assess the risk of bleeding using the Hasbled score. Okay, so hope you have understood the etiology, how the atrial fibrillation starts and how it progresses, how will the patient present, how are you going to diagnose, and how are you going to manage the patient that has come to you. This is all about atrial fibrillation. Hope you like this, and if you like it, send this to your friends, subscribe and give it a like. That will encourage me to do more and more videos like this. Thank you.